we have Mike? All right. Welcome back for our third live session. This is a follow-up to our second case, tooth number 18. Lower molar treated with minimally invasive coronal shaping and gentle wave cleaning with bioceramic Cedar and the abbreviated continuous wave of condensation technique. This is you see the pre-op case here. It was one that had carious invasion of the pulp chamber. Pulp chamber is not too small, but the mesial root is really wiggly. It's very thin. You can see a little bit better over here on the CT actually. Let's pull up another image. And this is difficult to see, but actually you can see it's a little bit rough. But here's the mesial view of the mesial root, and we're only seeing the coronal half. Here's the apical half. So when you see them side by side, you'll know. Actually, I need to probably be over here. You can see we have two canals that are confluent in the right about here, the apical third. The distal canal, single canal, relatively simple. It exits on the side of the root here. It's got about a 25-30 degree curvature. So the case, I thought, went pretty well. We've got a beautiful list of questions to answer that were asked. Very relevant, very helpful to other people that are interested in this. I want to start off by showing the finish of this case, however. The distal canal had a very severe apical curve. Mesial had 1, 2, 3, 4 curvatures in it. The last curvature being more than 45 degrees. All told about 75, 80 degrees. And here's the blow up of that. You can see the curve here, and there's a bunch of surplus material right here. This is a lateral canal. The mesials came down and joined, and we see two openings here. Primary opening, which is easy to see. This guy on the side is really tough to see in the mesial CT view. Here is a side. This is actually a 3D reconstruction. You can see, especially nicely, this distal root and the canal in it, making about 110 degree curvature, and the lateral canal is coming right off here. So when we look at this close up, we can see this little side canal I was mentioning. It doesn't show in the CT from the mesial view for some reason. So we're seeing the mesial distal views of the mesial distal root. I love taking post-op CTs. Tom McClammy is the one that got me interested in doing that. We take 40 by 40s on all of our final cases, our recalls, even our check visits sometimes. I think that's it for this case. So let's go over some of the questions. The questions were, as I said, really great. Okay, the first question. Why use the gentle wave system before instrumentation? The gentle wave system is really powerful. There's a lot of sonic energy, and it's in all these different frequencies. So if there's a certain geometry in the canal system or the pulp chamber that would only be ideally agitated and cleaned at a certain frequency, they're all in there, so it's going to be effective regardless of exact geometry. That's one of the amazing things. With that said, you don't need to have hypochlorite to clean pulp chambers. You can use the first minute and a half leak test and the initial wash that happens before the hypochlorite even comes on. Then I would use that, take a look and see if I can't find the canal I've been looking for. If I can, I will go ahead and thread a file through there with the platform in place and then put it back on and do the whole wash routine once each of the canals are ready to go. Next question. How to use gentle wave when you can't find a canal? I just basically described it to you. I'm going to cut an access. I'm going to find all the canals possible. If I'm frustrated, I'll go ahead and build a platform, do the first minute and a half distilled water, leak test and wash, and hope that that's going to open the canal. I've had a case in an upper molar where I couldn't find the MB2 even though I knew where it was. I used the gentle wave system and saw bleeding coming out of it, but it was so small, I still, even though I knew exactly where it was, I couldn't get a file in it. So it was basically just a really far apart, far set fin off the MD1 canal. Have I retreated any canals with BC Sealer? Only one. It was about the same as AH Plus or Thermoseal. Thermoseal is a hard setting epoxy. This happens to be a hard setting bioceramic, but even when it sets hard, it's a little harder than chalk. So I didn't find it any difficult to remove that. Obviously, there's got a percha cone through the middle of it. You've got a percha is removed, and then successively larger files are used to cut any further filling material off the canal walls before doing the cleaning procedure. Third question. Do I still use irrigating solution consisting of hypochlorite and lemon's scent? I don't. I used to use lemon scent off the in the bleach bottles that we bought out of the grocery store. It made it smell less like chlorine, and patients weren't as apt to ask, you know, what is that stuff you're using in my tooth that smells like bleach? And I don't have to tell them it's very similar. What file system do I use for instrumentation? I'm really, I'm at a crossroads. I'm trying everything right now. I'm trying everything from different ways to use my GTX file system with the hybrid technique, bringing in a shape memory, heat treated 2015 or 2004 or 2006. Quite often I'm using those to do my initial negotiation, then engage, figure out what the terminal diameter of the canal is, and use any kind of shaping file that has that same tip diameter with the taper that I want. So I'm using GTX. I've been using Vortex Blue, but they're too big at the shank end, so I don't really care for them that much now. I'm working on using the V-tapers by SS White. That was a nice system designed by Chuck Goodis, who owned the company at that time, owned that file system at that time, and it had really nice maximum fluid diameter limitations in the 2006. It doesn't get any bigger than 0.68 millimeters, I believe. And these are the files that are recreating the most natural look in the gentle wave cases that we're seeing, from Clammy, Steve Frost, all my close friends, Ryan Facer. We're all trying to get as small as possible, so we're trying all kinds of files. Sorry, I don't have a more definitive answer for you. If you want to understand how I've used GT files up until gentle wave, there's plenty of video on my website, endobuchanan.com or delendo.com. Check that out. How different are the methods I use today versus methods used 5 years ago? That's a great question. And the interesting part of the question is it's only 5 years that we're clocking time here on. Usually I look at how many things that we used in dental school do we still use today, and the answer is virtually none. The methods that have changed since the last 5 years, I would say, for sure, dynamic guidance, having a guided access capability to access calcified molars, calcified anteriors. That's huge. That's changed my practice enormously. I've always been a big fan of cone beam CT. If anything, in the last 5 years, I use it more often. I don't think 5 years ago I was doing all my post-ops and recalls with that. What else has changed? I'm doing heads-up magnification. I don't put my eyes in oculars anymore. Having a set of 3D glasses, little slim polarizing lenses on while I just look up at the screen and do my procedures is totally changing my experience in dental practice. I think it's going to extend my career by years. With pulp canal sealer, you recommend the plugger be 4 to 6 millimeters from the terminus, but with high flow, you recommend a shorter distance. What distance would you recommend with high flow? Because high flow BC sealer doesn't shrink upon setting, we do not have to thin the sealer layer out to minimize the amount of shrinkage away from the canal wall. That was the problem we had with all conventional sealers before now. Now, because the sealer isn't going to shrink, we don't care if there's a pool of sealer or if a lateral accessory canal or a third or fourth canal and the root is filled just with sealer. That's a great filling material. It's going to it's going to do the job. What we can do now, however, is literally just by cementing the cone in single canals that are in single roots, you're going to fill almost every lateral canal that is in that root. When you get to mesial roots of lower molars with a big wide isthmus, MB roots of upper molars, they have quite a rich network of, laterons and loops and fins and hoopy-doos. I feel like I need to downpack those further. Even in the single cone fill though, when I'm cementing the cone and most of the lateral anatomy is filled during that cementation process, I'm still going to sear the cone off at the orifice, and I'm going to hang out there for 2 or 3 seconds with the elements-free continuous wave electric heat plugger so I can heat the gutta percha there. Then I'm going to take a plugger that matches the diameter of the canal. Mine are usually 1 millimeter in diameter, so I use the fat end of the red #1 continuous wave hand plugger. It's 0.9 millimeters, so it fits perfectly in the orifice. Once I sear that off and sear the cone off and add some heat right there, take the butt end of the cone out, I plant a plugger on the gutta percha. I tell the patient I'm going to put a firm, sustained stroke on this for 10 seconds at least, and then I lean into it and hold it there because gutta percha moves slowly. That's going to tighten everything, and it's going to keep it from shrinking away from the wall as it cools at that level. In the canals that are in roots that have other canals in them, we're going to have isthmuses, and those I'm going to want to do a down pack, maybe to mid-root. The biggest difference is I'm not going to pre-fit my pluggers. My pluggers pre-fit in small canals go around curves. When I down pack around curves, I have to remove all the filling material and do a syringe backfill. I hate syringe backfilling, so I don't bend my pluggers anymore. I pick the largest one that'll go to mid-root, and I literally just sear the cone off, plant a hand plugger for a sustained condensation push. Then I put the cold electric heat plugger on the gutta percha at the orifice. I hit the button, and when it just bottoms out, I wait for 10 seconds. I'll hear 2 little beeps from the elements-free system telling me 10 seconds has passed since I've taken my finger off the button. I'll push apically, break it loose, tease the plugger out without disturbing the gutta percha and sealer that's already in perfect place. And I'm going to cement a backfilling gutta percha cone from Curry Endodontics. The backfilling cones are the same exact tip diameter and taper as all of the electric heat pluggers in the continuous wave system. Down packing to mid-root, backfilling with a backfill cone is the fastest three-dimensional technique I know of in terms of extensive lateral filling. With distance, again, it doesn't really matter how deep it goes. It is just not required that we get as deep as we did before. It's not required that we bend our pluggers. The final sizes. What were the final sizes you shaped all canals to in tooth number 18? I did tooth number 18. I dedicate that case to actually Tom McClammy because I did it as per his exact instructions. He's been leading the pack on this minimally invasive shaping, minimally invasive instrumentation run that's been going on with GentleWave. Really exciting. These cases, I've been teasing him. His nickname now for me is Walter Hess because his cases are so under-instrumented that they really literally look like Walter Hess models with all the little kinks and irregularities that we saw in his replications of the anatomy. So the final shapes, I had a 2004 in the I had a 2004 to lengthen all the canals. Did I cut any shape to speak of in the distal canal? Not really, but I was able to gauge and see that there was a step back in taper, so I fit an 04 cone in there. If I fit a larger cone without any shape being created, I'm likely to have a prematurity in the binding of the cone before I get to the end of the root canal. But I was able to fit a 3004 in the distal. I was able to fit a 2004 in the 2 mesials. Remember, again, those were shaped with V-tapers. It was simply a 2006, 2004 V-taper. Okay, question is, what about Cedar in the inferior alveolar canal? Well, first off, this case obviously didn't have any. We have a Cedar puff at the end of the root. You can see the post-op, what that was from. We had about a 110-degree curve and lateral canal coming off the top of that But I have personally never seen any sealer in any of the cases I've been working with into the mandibular canal. For the majority of my career until actually this last year, I used Kerr pulp canal sealer, which is ZOE prep, sets fairly rapidly. It tends to be less toxic in terms of biocompatibility than, say, AH+. It's the most toxic until it sets. And so if I did get it into the canal, it would be less damaging than almost any of the other sealers that could happen with. I think the point of the whole treatment routine and learning a predictable procedure to use with any sealer is we have to have the narrowest constricture, the narrowest diameter at the end of the root canal. If it's originally inside the canal because of resorption, we need to cut a shape that moves it to the end, and then we need to fit a slightly less tapered cone in that opening, about a ½ millimeter short. And if we do those two things, the only surplus we're going to have really is from accessory canals branching off in the apical third. Both of the cones in this case stayed exactly where I expected. They simply just scooted a ½ millimeter, so they ended up right at length. And the cedar puffs, the mesial and distal root, are from the accessory canals. Okay. But anything at all in the IA is obviously, IA canal is obviously bad. I will say this about the biocompatibility. One of the very first cases I used BC sealer on, I accidentally locked their plastic tip in the orifice of the canal, so when I carefully syringed the sealer into the canal, it actually shot past the end of an upper premolar. I had a little sealer puff, it's more than a puff, it was about 4 millimeters in diameter, so really ugly. Called the patient that night, patient didn't even take in a leaf. So the biocompatibility is remarkably good with this. And one of the interesting things about that sealer to me is it's biocompatible to patient tissues, and it's highly antimicrobial because the small amounts of calcium hydroxide that are liberated upon its set. When you apply the sound seal platform for GeneWave and then refine the access cavity, couldn't you have put a piece of foam from the endo ring inside the access before applying the material and curing? Yeah, absolutely. This probably is a question from Ryan Facer, because that's his technique, and I think it's a great one. You know, Ryan, I'm probably using a new technique in every case I use. Sometimes it just takes me a couple to get the latest thing in place. I'm working on creating a preset, pre-assembled platform assembly design, and the foam will be a part of that. So that's a great idea. When Ryan takes finishes making the platform and takes the platform former off the top of it, he usually uses a number 40 headstrom file, I think, in a rotary handpiece, and just runs it down through, then it winds up the sponge and pulls it out in one fell swoop, and then there's a lot less debris to cut around the edge. So that's a great technique. If this is your question, thank you, Ryan. If it isn't your question, thanks for the technique, Ryan. What's the microscope system I'm using? Why is everyone wearing 3D glasses, and why is it different from the classic dental operating microscope? Microscope I use is either MoraVision or a TrueVision heads-up 3D heads-up camera system. Basically, it just goes right on top of the microscope body. It replaces the oculars, so I don't have oculars to look at anymore. I'm looking up the screen. The reason everybody's wearing 3D glasses is because it looks like you're having, you know, crossed eyes if you don't have 3D glasses on when it's being presented as 3D. So everybody wants to watch the image either here or on my monitor. Got to just wear these little thin Polaroid clip-ons. They flip up. The only problem with those is you got to make sure you don't wear them outside the office. You'll look like a nerd. But it's a remarkably simple system to use. It's a remarkably more relaxed way to operate. When I have my eyes in the oculars, even with extended oculars, I'm severely limited. I can usually not put the camera body down over the patient's torso and aim up at their maxillary teeth. Right now I do accesses without a mirror on maxillary teeth all the time. It's really simple. So that's one of the coolest new technologies I've ever used. As I said earlier, I think it's going to extend my career by a number of years. Okay. Last question. What's the portable handheld x-ray device? That is a Nomad x-ray device. They are fantastic. The worst part of Taking working films is trying to get those unwieldy sensor holders that work around rubber dam frames, around rubber dam clamps. What I've evolved to is using a rubber dam frame that has a hinge at the top and bottom. You just hinge it open, you have perfect access in there. I want my sensor on a little stick so I can hang on to it, and I can put it in there. There's very little extra material around it, so it slips in there very simply this way, and then I flip it around, tell the patient to lift their tongue, drop it under their tongue, and now I've already got this handheld x-ray unit. I'm holding this, I bring this in, get it just right. I'm looking at both of the x-ray head, the sensor, and the tooth, and I shoot it, and then I'm going to wait, watch for it to come up in 4 seconds. If I don't like it, I slightly change the angle, shoot it again, and I'm ready to go. The question after the followed that was about the zone of radiation and why the assistant didn't move. There's number 18. She's sitting away from me. I'm sitting here. The patient's between us. I'm shooting across, so it wasn't aimed at her. That's why it was. She didn't move. There's not. The radiation from digital radiography is unbelievably small. The smaller it is, the less energy it has. The shorter distance it'll move before turning from radiation into heat. Most dentists don't even know that 6 feet away from an old, crummy analog x-ray system that went for like a half a second, it's only 6 feet. 6 feet away from an old system was the x-rays turned to heat. There's no more radiation out there. Now we have barely a 1 foot area around the nomad. You can see there's a little bit of a ring around it that shields things from coming back on the operator's hand. But literally, I could aim it right at you, and if you're 2 feet away, it's going to have zero effect on you. So we need to inform our patients and our assisting staff about that. When assistants don't understand this, they're going to act in anxious ways. They will telegraph anxiety about the hazards of dental radiation that really are almost non-existent. If they book out of the room when they set it up, and they're really acting worried about being in the same room, it's not the right message to send to a patient. As I said, you could be anywhere in the room. With the old system, within 6 feet, you're good. It doesn't ricochet around the room like a bullet. One of my assistants actually thought that after the cone beam CT machine stopped running in the room we used to have it in, that there was resident remaining radiation in there that had to die down over a period of time. We were able to put a radiation sensor in there and show her that 4 feet away from the CT machine there was no radiation even while it was operating. And that's generally true of CT machines as well. That ends the questions for this case. We're working our way through this new technology. It's very exciting to be able to broadcast live to anywhere in the world. I've been waiting for this to come to fruition for about 15 or 20 years. And that is going to do more to share techniques with other dentists around the world than almost anything else we've done in dental education besides 3D printing. So this is a wonderful medium, a great way to communicate. I love doing live demonstrations because it just kind of ups the ante, makes it more interesting. You have to be willing to accept some cases that turn out less than ideal, but when live demos are done and they don't turn out ideal, that's actually the best experience for course attendees, because they want to see how you get out of trouble when everything doesn't go perfectly. But we're working on the setup and the technology. We need to get cameras and microscopes hung out of the ceiling instead of on stands around here. But trust me, we're going on our 3rd live demo next week. This is a form of communicating and sharing knowledge that we seriously believe in, and we'll be doing everything we can to make it better every time. So thank you for joining us. Hope to see you next week for the live demonstration. I don't have the case yet, so I can't really tell you what it is, but we'll pick the best from my patients at the time, and you'll get if you watch this, you'll get a reminder that the next live demo is coming up. Thank you very much.